Yes. So we discussed about classification of burns and how to calculate the degree of burns and how to calculate the surface area, total body surface area that is burned, right? Now we will focus on the management of the burn. Major determinants of the severity of any burns are percentage total body surface area that is burned, presence of an inhalation injury, presence of any respiratory distress, patient under the age of 2 years and over age 60 years. Right. Then depth of burn. Okay, how much epidermis and dermis is damaged now. So today we are focusing on management. When is patient referred to any burn center? When there is suspected airway or inhaled injury. Any burn likely to require fluid resuscitation. Any burn likely to require surgery. Partial thickness or full thickness burn. Yes. Partial thickness or full thickness burns totaling greater than 20% of total body surface area in other age group. अगर तो partial thickness or full thickness burn 10% है in any patient under 10 years or over 50 years, so that is categorized in severe burn injury. ठीक है. Means patient must be referred to burn center. If partial thickness or full thickness burn 20% है जो कि 10 to 40 years की एज ग्रुप में आ रहे हैं. So below 10 and over 10% is considered severe burn injury and must be referred to burn center. Burns in the patient with pre-existing medical condition, जिसको पहले कोई रीनल डिसऑर्डर है, कोई पहले ही लिवर डिसऑर्डर है, उसके अंदर मैनेजमेंट इज मोर इम्पोर्टेंट. ये तो जनरल आपको मैं बता रही हूँ कि मैनेजमेंट को आपने कैसे लेके चलना है, पेशेंट को कैसे रेफर करना है. Any burn with associated potential serious sequelae, including high tension electric burns or concentrated hydrofluoric acid burns, must be referred to the burn center. If before going hospital, pre-hospital, you must ensure rescuer safety first. ऐसे नहीं कि बर्न आप बचाने जाओ खुद भी साथ उसके अंदर कूदो, खुद भी कूद जाओ, ऐसे नहीं करो, क्योंकि वो अपनी सेफ्टी को पहले इंश्योर करें. स्टॉप द बर्निंग प्रोसेस. ड्रॉप एंड रोल इज अ गुड मेथड. ठीक है. आप सबसे पहले रिमूव द क्लोथिंग फर्स्ट, देन चेक फॉर अदर इंजरीज. Follow ATLS guidelines. Cool the burn wound. Cooling for 10 minutes is effective to reduce pain and to slow down the microvascular damage. Cooling should be at 150 degrees Celsius and hypothermia should be avoided. Give oxygen. Elevate of the burned limbs may reduce swelling, and sitting a patient with burned airway may prove life-saving. Right. So now it is clear. First of all, manage airway. Assessment of percentage of the burned area. Assessment of the depth of burn. and involvement of any surrounding burn injury and assessment of associated injury. Now, how to assess the total body surface area? I told you कि rule of 9 is in our common practice, and palm surface area 1% that constitutes is a common practice. And how to assess the airway? Always look for airway. Check for the physical burn to the nose, palate, tongue. It can cause laryngeal edema, and emergency endotracheal tube intubation and cricothyroidotomy should be considered. The time frame from burn to laryngeal edema is really between 4 and 24 hours. The treatment of inhalation injury includes chest physiotherapy, nebulizer, warm humidified oxygen, and assisted ventilation may be needed. Look for the development of symptoms, change of voice, stridor, and respiratory difficulty. Right. Now, first of all, आपने airway को assess किया, second percentage of burned area को assess किया, depth of burn को assess किया, then surrounding area में कोई injury है उसको assess किया, then assessment of associated injury. Now come up to the hospital management. Let me open. Now, what happens? How burn injury causes renal disorder? Because in case of burns, myoglobin is released from the muscles that causes renal injury. We have already discussed about this. Palm method. Patient palms. The size of the patient's palm is approximately 1% of the total body surface area. Now calculate by placing palms. Now I have already told the criteria: minor and major burn. Minor burns is second degree burn of less than 15% of total body surface area in adults or less than 10% total body surface area in children. Third degree burn of less than 2% total body surface area not involving special care areas like eye, ears, face comes in minor burn. Second degree major burn किसको कहते हैं? Second degree burns exceeding 20% total body surface area in adults and 20% in children. And the third degree burns exceeding 10% total body surface area. हमने क्या पहले डिस्कस किया था कि पेशेंट का हॉस्पिटल रेफरल लेस देन 10 एज और ओवर 50 इयर्स एज, अगर 10% बर्न हो रहा है तो पेशेंट को बर्न यूनिट लेके जाएं. एंड इन एल्डर in the middle between the 10 and 50, 20% is the criteria to refer to burn unit. In minor and major, how we categorize? Second degree burn of less than 15% total body surface area in adults or less than 10% in children. Third degree burn of less than 2% total body surface area not involving, अगर 2% है तो आप उसको minor में लेके जाओगे. Major burn क्या कहेंगे? Second degree burn exceed 25% total body surface area in adults and 20% in children. All third degree burns exceeding 10%. Local and systemic responses to the burn. Burns that do not exceed 20% total body surface area produce a primary local response. Burns that exceed 20% produce both systemic and local responses and are considered major burn injuries. The systemic responses are due to the release of cytokines and other mediators into the systemic circulation and include the following. Tissue edema effects on fluids, electrolytes, and body volume. Cardiovascular responses, decreased cardiac output, hypovolemia, decreased BP, increased PR interval. Pulmonary responses, inhalation injury to the airways, bronchoconstriction, major cause of death, acute respiratory failure, and acute respiratory distress syndrome. Altered immunological defenses and renal dysfunctions. Pathophysiological changes resulting from major burns during the initial burn shock period include tissue hypoperfusion, organ hypoperfusion secondary to decreased cardiac output, hyperdynamic and hypermetabolic phase. Because in burns, metabolic rate is increased, energy expenditure is increased, right? So, in severe burns, some 7,000 kilocalories may be expanded. बॉडी के जो ग्लाइकोजन स्टोरेज एंड फैट स्टोरेज हैं वो यूटिलाइज होना शुरू हो जाते हैं जिसकी वजह से पेशेंट कैटास्ट्रॉफिक स्टेट में जाता है. उसने बात की है द इंसिडेंस मैग्नीट्यूड एंड ड्यूरेशन ऑफ पैथोफिजियोलॉजिकल चेंजेस इन बर्न्स आर प्रोपोर्शनल टू द एक्सटेंट ऑफ बर्न इंजरी with the maximal response seen in burns covering 60% or more total body surface area. The initial systemic event after a major burn injury is hemodynamic instability resulting from the loss of capillary integrity and subsequent when capillary integrity is lost, proteins, albumin is lost from the fluid, from the capillary bed and fluid ooze out from the vessels. So subsequent shift of fluid, sodium and proteins from the intravascular space into interstitial spaces, right? Burn care must be planned according to the burn depth and local response, the extent of the injury and the presence of systemic responses. Burn care then proceeds through three phases: emergency and resuscitative phase, intermediate phase and rehabilitation phase. Although priorities exist for each of the phases. Now, phases of burn care. Immediate resuscitation from onset of injury to completion of fluid resuscitation. First aid, prevention of shock, prevention of respiratory distress, detection and determinant and treatment of concomitant injuries. Acute from beginning to of diuresis to near completion of wound closure. Wound cure and closure, prevention or treatment of complications, rehabilitation from major wound closure to return, prevention of scars and contractures, physical, occupational, or vocational rehabilitation, functional and cosmetic reconstruction, and psychological counseling. Yes. Now let's discuss about management, pre-hospital management and hospital management. In pre-hospital management, remove the clothing first and manage airway. Look for the remove the patient from the scene of burning. They can give oxygen, elevate burned limbs, and prop up patient so that airway maintain हो सके. Now the hospital management में airway and breathing first of all, then come about fluid resuscitation. Ringal lactate is the fluid of choice, and the Parkland's formula calculates the need of the body for the first 24 hours. It is yes. Let me yes. Fluid replacement therapy, the total volume and the rate of intravenous fluid replacement are gauged by the patient's response. The adequacy of fluid resuscitation is determined by output total of 30 to 50 ml per hour, systolic blood pressure exceeding 100 mg and pulse rate less than 110 per minute. होता क्या है? Conditions leading to burn shock, increased vascular permeability, I told you, decreased intravascular volume, increased hematocrit and viscosity, increased peripheral resistance and burn shock. जब अंदर से प्रोटीन्स लॉस हो जाएंगी, फ्लूइड उधर जाएगा जहाँ पे सॉल्यूट्स हैं, सो वेसल से बाहर वाटर आ जाएगा इंटरस्टिशियम में, इंट्रावास्कुलर से इंटरस्टिशियम स्पेस में आ जाएगा अराउंड द सेल. सो फ्लूइड कंटेंट वास्कुलर का कम हो जाएगा. फ्लूइड रिक्वायरमेंट, some combination of fluid categories may be used: colloids, whole blood, plasma and plasma expanded, crystalloids and electrolytes जैसे कि रिंगल लैक्टेट आ जाता है. Adequate fluid resuscitation results in slightly decreased blood volume levels during the first 24-hour post-burn hours, and it restores plasma level to the normal by the end of 48 hours. Oral resuscitation can be successful in adults with less than 20% total body surface area and children with less than 10 to 15% total body surface area. I've already told you कि बॉडी का मेटाबॉलिक रेट इंक्रीज हो जाता है, जिस तरह से बॉडी को एनर्जी एक्सपेंडिचर ज़्यादा एनर्जी चाहिए होती है, जिसकी वजह से बॉडी के रिजर्व ग्लाइकोजन स्टोरेज यूज होना शुरू हो जाते हैं. नाउ व्हाट इज द Parkland's formula? 4 ml into body weight in kgs into total body surface area. And I have already told you greater than 25% total body surface area comes in severe burn. So let 25 take a 25% total body surface area. Let's suppose weight is body weight is 60 kgs का, 60 into 25 into 4 ml. It is 6,000, right? 6,000 means 6 liters. So in the first 8 hours you will rush about 3 liters fluid, and the remaining 3 liters in the next 16 hours, right? Here it has taken 70 kgs and 50% burn. Sorry, 70 kg and 50% total body surface. That is a severe burn, and patient ultimately, if patient could not revive, then ultimately go into septic shock, hypovolemic shock, and multi-organ failure. Right? I already told you ki how the renal disorder come. The myoglobin from the byproduct of blood goes into the circulation and it impairs renal function. उसने it took about 17 to 15 to 4. 70 into 50 into 4. This 14,000 means 10 to 14 liters इसमें जाना है पेशेंट को. So first infuse with 5 to 6 liter in first 8 hours. 2 into 70 into 50. Basically it is 4 ml. So 4 into 70 into 50. 14,000 mLs. So 14 liter. So infuse 7,000 ml in the first 8 hours and 7,000 ml in the next 16 hours. Stick half to be given in the first 8 hours, remaining half in the next. Day 2 पे half of the previous day's colloids and electrolytes, all of insensible loss. Then hypertonic saline solution, concentrated solution of sodium chloride and lactate with concentration of 250 to 300 milliequivalent of sodium per liter administered at a rate sufficient to maintain a desired volume of urinary output. Do not increase the infusion rate during the first 8 post-burn hours. Serum sodium levels must be monitored. In the burn patients, electrolytes measurement is very important because our body requires a proper electrolyte balance because our nerve excitability is dependent on it. Our uh, maintenance of cell membrane potentials for the working of or the integrity of our nervous system, it is important. For the nerve excitation of any part of your body, like muscular junctions, the nerves excitability. Yes. Now, after managing airway, after calculation of fluid resuscitation, now what is the treatment must be offered? Infection prevention, wound cleansing, administration topical antibiotic drugs, antibacterial drugs like sulfur, sulfadiazine, silver nitrate, mafenide acetate, then hemodynamically stable through diuresis, capillary permeability is restored after after administrating colloids, and 48 to 72 hours after injury. Goal is restorative therapy. Focus on infection control, wound care and closure, nutrition support, pain management. Diuresis from fluid mobilization occurs and the patient is no longer grossly edematous. Bowel sounds return, healing begins, formation of granulation tissue. Now, what is meant by uh, asterotomy? A scar is a coagulative necrotic skin formed as a result of deep burn. Unlike normal skin, this scar is rigid and cannot be expanded. When there is deep burn, there is a loss of epidermis and dermis. So, the dead necrotic skin is a scar, and the beneath structures that are compressed by this dead necrotic substance, applying pressure on the underlying limb vessels, leads to ischemia of the underlying muscles, causes muscle necrosis, and this is called compartment syndrome. To avoid this, asterotomy should be performed. Asterotomy is what is this surgical incision over the eschar, that necrotic skin. Okay. Because fluid and protein extravasate from the tissues beneath this inelastic eschar. So if there is any circumferential burn of the limb, this eschar over it may act as tourniquet and can hamper the vascular supply of this limb. This is called asterotomy. For the pain management, opioid every 1 to 3 hours for pain, several drugs in combination, morphine with haloperidol, non-pharmacological strategies, relaxation, visualization, guided imagery, mediation. Right. This is showing you surgeon harvesting skin. Now, energy balance and nutrition. Patients who have burns are at higher nutritional requirement because their body goes into the catabolic state, because बॉडी की ग्लाइकोजन स्टोरेज यूजेस हो रहे हैं, फिर fats यूटिलाइज हो रहे हैं, who suffer more than 15% of total body surface area, and patient का 0.5 kg to 1 kg weight loss होता है daily severe burns में. If a patient has greater than 20% total body surface area burns, a nasogastric tube is introduced and feeding started within 6 hours after the injury. This reduces the mucosal damage to the gut, because inhalation injury causes damage to our respiratory tract. If the burn is much severe that skin and epidermis and dermis is lost, then mostly the muscles and the organs become visible in severe and deep burns. Infection prophylaxis, because these patients become immunocompromised with a large exposed surface area created by burns due to the impaired local defense mechanism. एडिशनल मरीज में आप नर्सिंग केयर करेंगे, फिजियोथेरेपी करेंगे, साइकोलॉजिकल सपोर्ट करेंगे. Acute duodenal ulceration and multiple gastric erosion may follow burn patient. Early resumption of feeding and H2 blockers or PPI prophylaxis reduces the incidence. This is all about, this is showing the split thickness skin graft. If you're looking at, this is graft. Graft can be taken from the nearby skin area. इसमें हार्वेस्टिंग टेक्निक भी होती है. Rehabilitation phase is defined as the beginning when the patient's burn wounds are covered with skin or healed and the patient is able to restore a level of self-care activity. Complications, skin and joint contractures, hypertrophic scars. This is contracture. This is all about burn. Now, what are the complications of the burn injuries? Hypertrophic scars, keloids, cosmetic problems, patient psychological issues आ जाते हैं. Mental trauma है, this is depression. Right, this is all about today's topic. You must read it from your book. What are the non-thermal burn injuries? These are the chemical injuries, cold injuries, ionizing radiation injuries, and electrical injuries. In electrical injuries, we categorize it with the low tension and high tension injuries. In low tension comes domestic appliances, electric burn, like आपकी underlying nerve and tendon damage might vary. In high tension energies, what happens? Patient person can be injured by flash, flame, or by the current himself. When the high tension line is earth, enormous energy is released as the current travels from line to the earth. This can cause flash burn, the extreme heating of the air can cause explosion. And what happens, the damage to the underlying muscle can cause compartment syndrome. And release of myoglobin in the circulation, it can cause myoglobinuria and there's acute renal failure. Where acidosis can also occur. Let's we discuss acid or alkali injury, typically characterized by chemical burns. In chemical burns, what happens? Basically, acid damage is more severe and drastic than alkali. Acid tends to cause coagulative necrosis of the tissue, forming impermeable barrier, and in contrast, base alkali causes combine with cutaneous lipids to create soft, and they will continue dissolving the skin and until they are neutralized. डिसॉल्व किए जाएगा स्किन को अंडरलाइन स्ट्रक्चर्स को until उसको हम न्यूट्रलाइज जब तक नहीं करते. So it is very important to manage and to identify what type of chemical injury and urgent intervention is needed. This is all about burn injuries and इसके साथ ही हमारा चैप्टर खत्म होता है. Next, I will take interactive session and I will listen from all of you and I will I'm looking forward to your for your positive response and for your positive thing. You will learn and you will question. Basically, the next will be the question answer session. You will ask questions from me. So हम उसको डिस्कस करेंगे. Thank you so much. अल्लाह हाफिज़.